Hello, everybody. Warm welcome and good afternoon to our autumn budget analysis webinar. If you're expecting something a lot more exciting, although frankly this year's pre and post budget times were quite exciting as those things go, please feel free to sort of drop away now and no one will judge you. Otherwise, today what we're going to be doing today in this webinar is having a little look at the budget through the lens of practices and PCNs, and the individual GPs and practice managers working within them. And so the implications on our personal financial positions too. And we'll do this in a tag team fashion between Paul and I this afternoon. So let me introduce myself first of all. This is me. I'm Dr. Clare Sieber. I'm a GP based in West Sussex. I have a legal and LMC type of background, and I sit on GPC England, although I'm not one of their negotiating team. And I also spend a lot of time as a mediator of GP partnership disputes or PCN disputes. And ultimately, sadly, those often boil down to being about money. So I think with all of that, I have a fairly good understanding of the GP contract and how a lot of practices set themselves up both from a sort of business and a service delivery point of view. Paul, would you like to introduce yourself briefly, and then I'll take our audience through what we'll be covering today.
Thanks, Claire. Good afternoon. The easiest description around me is that I'm very much involved in all things doctor, NHS Pensions, practices, LMCs, and so on. So I try to ensure that myself, and indeed the whole team at Atomos have a full understanding as to what's going on, particularly around the pensions, because they've become ever more complicated with evolving changes that we're finally starting to see come through as we speak. So we'll try and outline how they can impact you or the practice, but also moving forwards, what it'll actually mean, and hopefully the good news that it will bring eventually, albeit along the way it can feel quite painful.
Thank you, Paul. Right, let's just take you through what we'll be covering today in our kind of dual effort. I'll kick things off at the beginning with some headline changes from the budget announcement and talk about the impact that these might have on the practices and PCNs. And in doing so, I'll pick up on a lot of the questions that you very kindly and helpfully submitted in advance. And then Paul will talk more about the personal financial side of things and what trends he's seeing at the moment and what effect, if any, this budget might have on those and retirement and such. And then and hopefully we do have some time at the end, then we can do a bit more of a live Q&A. So to that end, please do put your questions and comments in the chat or the Q&A, and I'll try and keep an eye on those as I kind of go along. This is being recorded, and both the slides and the recording will be emailed to everybody who is registered to attend probably next week, which I hope means you can relax a little bit while you're watching this and just enjoy Paul's jokes. So let's kick off with the key announcements, I guess, from the budget that I think are going to have the most impact on practices. So we got the national living wage, which is rising from April next year, and the national minimum wage is also rising from April next year. We're seeing income tax bands, personal allowances, and national insurance contributions thresholds being frozen further now until 2031, which is, to all intents and purposes, a sort of widespread tax rise, both on us as individuals and practices and PCN, so on businesses too. And that might mean in time that more of us might get caught by what's called the marginal rate tax trap. If you don't know, if you'd like to know more about that, when you get these slides through, you'll see that little link will take you through to what I think is a very useful kind of summary of what that means. Effectively, it means that if we're earning between 100 and 120-ish thousand pounds, then that bit of our earnings gets taxed at 60%. And that's what's known as the tax trap. There were some other kind of big fanfare announcements, if you like, in the budget that might have an effect on us as practices and PCNs. Firstly, there's this additional £300 million to be spent on digital infrastructure. This is capital rather than recurrent funding that's coming through So with a simple brain, I'm thinking hardware, computers, keyboards, cabling, that kind of thing. And then there's also been an announcement of 250 new neighbourhood health centres. So premises where services are co-located alongside GP practices, such as physios, midwives, health visitors. Some of that doesn't sound too unfamiliar and might hark us back to nice days. And there's this aspiration to have 120 of those by 2030. It looks like Paul's desperate to say something already. Is that right, Paul?
No, yeah, we're okay. Although I'm familiar with the health centres, and I think the master plan does work, but there are some steep hurdles on that one to negotiate.
There are not just, of course, how it's going to be funded, and there's talk of what they're phrasing public-private partnerships, sounding a little bit like PFI, which of course is still being paid by the taxpayer. And so some of the detail there is still to be ironed out, and people are naturally very cautious of that because we have history to thank us for the cautiousness there. So what does all of that sort of mean, and particularly in the context of what might be coming next year when those staffing, the wage rises hit in terms of the 26-27 GP contract? That was a question that a lot of you asked. And well, helpfully, maybe Wes Streeting has sort of already put his position to the DDRB of what he feels is affordable next year, and has said that the financial plans that the Department of Health and Social Care are kind of working to currently allow for a pay uplift of 2.5%, which you could maybe extrapolate and say that that's them setting the scene for a 2.5% GP contract uplift kind of in its entirety, perhaps. We know the value of the GP contract has been eroded year on year, and ultimately then that gets felt on partner profits. We know that staffing costs are the biggest costs for any contractor, so a rise in the national living wage and then maintaining the wage differential with all of the other staff that aren't on that will further increase staffing costs and further reduce partner profits. And as I said, it's looking like maybe there's some early warning signs that the contract uplift in 26-27 might not be great. And then, of course, the DDRB will make a decision about the pay award, the uplift for salaried GPs. And even if that does get passed on in full, which is what happened this year eventually, although it came a lot later, what contractors find is that what is passed through isn't applied to 100% of the global sum. Instead, it's applied to a proportion of the global sum that, when the contract was negotiated in 2004, so over 20 years ago, was felt to perhaps reflect the proportion of global sum spent on staffing. And for a lot of practices, certainly those who operate a traditional model of few partners and more salaried staff, that is kind of that percentage is applied to less than the percentage of their global sum that they spend on staff. So again, that's something that then gets funded as and then reduces partner profits. So what could we see as a result of that? Well, perhaps we'll see, because everything's a bit tighter, there might be less of a desire amongst younger GPs to become partners. Partners at the other end might think, well, this is the final straw. I'm going to now walk out of the door that Paul's going to talk to you about in a minute into happier retirement land. So retention could be an issue too. Practices might think, right, we're going to do a recruitment freeze now. I know some have already done that this year. We might see more doing it. We might see practices trying really hard to cap their locum spend and just taking a workload hit themselves to rein in the locum spending. We might see more practices finding it difficult to pass on the DDRB award to salaried GPs that are entitled to it in their contract, and then sort of amplifying the slight tension that there is at the moment between partners and salaried colleagues. And we might see practices thinking a little bit more differently about their business structure and maybe looking for a model where there are fewer employees and perhaps more partners or more kind of contracted locum members of staff. So those are my thoughts. I'm interested to know whether that rings true with any of you, and you're welcome to stick a comment in the chat and let me know whether I'm kind of close to what you're thinking. Paul, I'll hand over to you now to take us through some more of the kind of personal stuff and the retirement stuff.
Thanks, Claire. As Claire outlined in the agenda, we'll run through the three schemes. So how they impact you if you're a member of any of the three, what options you have in terms of when you can access them for retirement, but also, and this is crucial to this first slide, final pay controls. So we've seen the uplift to minimum wage, living wage as well. There is a relevance, and final pay controls is potential hiccup. So anyone that joined the NHS pension before April 2008 originally joined this scheme, 1995 scheme. So for the majority, the normal retirement age will be 60. If we have any nurses or psychiatrists or midwives listening in, potentially your normal retirement age in this version of the scheme could be as early as 55. For everyone listening in, it's imperative now that you access your latest estimate of benefits. I'm very mindful of how PCSE does or doesn't process everything on time. But what is absolutely essential to you as the individual, but also the practice moving forwards, is that year by year you receive updates that are relevant to you. And what we see quite often, particularly for GPs, if you've been salaried at any stage, you need to complete a Type 2 certificate. If you're retiring in 6 months' time, that's plenty of notice to give PCSE the AW8 form and so on, and I'll come on to that in a moment. But if your records are not up to date, you will not be receiving your pension on time. And in fact, it could take several months beyond your retirement date, if not worse, before matters are resolved. So back to the actual schemes. So normal retirement age of 60, great news. And then you'll see the second bullet point, which differs, 1.4% or 80th. It depends if you're a GP or an employee. And by GP, I mean everything from locum, salaried, and indeed partner. If that is you, you effectively build up a pension based on 1.4% of your pensionable earnings. So simplifying that hugely, if you earn 50,000 a year, 1.4% of that is about £700 a year as a pension. If you're an employee, so if you're a practice manager, and that also includes partners that are non-clinical. So if you're a non-clinical partner, you're deemed to be an employee for this version of the pension. And you accumulated benefits based on 1/80th of your final salary. And final salary for this one is crucial. It's deemed to be the best of the last 3 years at retirement or leaving the scheme. So if anyone has ceased paying into the pension 5 years ago, the clock would have started 5 years ago, the year before, the year before, and the year before that. Whichever one of those three had the best pensionable pay, that will be the figure used. If you're retiring next year as an employee, and this is your current highest ever salary, it'll be this latest year that's being used. So a very fair system, no doubt. And the extraordinary part, despite no one now being able to pay into this scheme, if you've had continuous membership, the final salary link remains. So for those of you that have friends within the hospital framework, consultants or similar, their final pay increments have increased recently over the last few years. If they kept paying into the scheme, their pension is now based on a much higher figure. The same can apply to you. Automatically, you receive a pension and lump sum. And one of the rumours prior to the budget, we had nigh on 2 months of worry around Rachel Reeves is going to take my lump sum. Rachel Reeves is going to tax the lump sum. She's going to limit how much I can take tax-free. None of that happened. The only factual information we could give to clients is that HMRC said if you take a lump sum from a pension, you are not going to be able to put that back into the pension should you change your mind. And then about 2 weeks before the budget, we had an announcement, we're not going to tax lump sums. So within this scheme, you receive an automatic pension and lump sum. And then the final bullet point that I mentioned earlier on, for those of you that have employees within the practice that have access to this version of the scheme, so that have carried on paying into the scheme and so on throughout, even though they're now in a brand new scheme, which we'll spend some time on in a moment, if they receive a significant pay rise, and significant is significant these days, it's now 7.5% plus consumer price index. If they receive a pay rise and then retire too soon, potentially the practice will be liable to make good the shortfall, the cost of the increase to that pension. And the reason it was created effectively was to stop husband and wife teams. One would be a GP, one would be a practice manager. My wife, the GP, would give me a pay rise with a year to go because it was the best of the last 3 years of pensionable income. Paying in for 1 year on that much higher salary would give the family, the two of us, a much greater set of pension benefits. Well, that was effectively outlawed. Now, there are workarounds. If you are a partner, non-clinical partner, you haven't adjusted your sessions and your income has risen, that's okay. If you have moved from administrator or assistant practice manager to practice manager, and there was an external option, so you put the job out to tender effectively and you welcomed external applications, then potentially that can fulfill the criteria required. But it's absolutely imperative that if you're giving out pay rises, significant pay rises, even if there's an uplift in role, you're aware of final pay controls. And I'm mindful this is being recorded. So one thing I would say is that if you have a medical specialist accountant, if you mention final pay controls, because either you're uneasy around it and you're concerned, or you're just trying to delve in to understand how it would work and how it could impact because you're about to offer a pay rise or a new role to someone, the better accountants will give you an answer. Those that are less aware may well Google for the answer, and final pay controls is not a Googleable or ChatGPT answer at the moment. It will be in the future, but just not yet. Next slide, please, Claire. Okay, so who joined the NHS pension before April 2008? Sorry, after April 2008, but before April 2015. If you did, this is the version of the scheme you joined initially. And you can see things have just shifted back. Rather than a normal retirement age of 60, it's now shifted back to 65. But to compensate, there are greater pension benefits available. So previously it was 1.4%, it's now 1.87%. So a much higher proportion of your income would be represented in your pension when you retire. For employees, rather than 1/80th, it's 1/60th. But the 160 is calculated on a slightly different basis. It's the average of the best 3 consecutive years within the last 10. So this really works well if you are, and we'll use practice manager again. If you're a practice manager and 5+ years out from retirement, you wish to step down to assistant practice manager. Well, if you did so and your hourly rate reduced in the old scheme, because it's more than 5 years from retirement, not in the last 3 years, potentially you'd end up with a lower pension. You could protect the pay, but potentially you'd end up with less. In this version of the scheme, it would still be based on the practice manager income because it's the average of the best 3 consecutive years within the last 10. So it's fairer in its calculations, but it just needs to be understood. The one big change, aside from it being 65 as a normal retirement age, there's no automatic lump sum. So if you'd like a lump sum in this version of the scheme, or indeed the 2015 scheme, so the new one, you have to give up £1 of income for £12 of lump sum. And crucially, you decide that at retirement. So anyone that's familiar with the AW8 or the AW8P, the forms you would complete to fill or complete to retire with your teams or indeed you individually, there are sections that ask, would you like a larger lump sum or would you like a lump sum? Yes, please. Would you like a monetary amount, or would you just like as much as possible, or as much tax-free? So there are plenty of options, but you decide them when you're planning to retire, not before. Now, this hasn't been a popular question. Whenever Claire and I have spoken on the same conferences, is anyone willing to use emojis or similar? Is anyone planning on retiring later than 65? Claire, not even you flinched at that one, so I'm guessing. Oh, hang on. We have a yes. Very good. Well, if this is the version of the scheme you're a member of, there's a late retirement factor. There'll be an enhancement to the pension as a result. Similarly, it exists in the new scheme as well. So it's really a question of trying to balance retiring late, because one thing that's for sure, having a late retirement factor will be wonderful. You'll end up with a vast pension, particularly if you retired as late as 75. However, do not Google life expectancy retiring at 75 from the NHS. You'd have an enormous pension, a very brief period to spend it, statistically, but it's worth being aware of because it is relevant. There, can we have a next slide, please? Okay, this is now the scheme that everyone is paying into. So regardless of your start date, this is the version of the scheme that will apply to everyone. So yeah, you'll have heard about the McCloud Judgement or the age discrimination case. I'll come on to that in a second. But in terms of the actual scheme, very different. No distinction now between GPs and employees. It's the same scheme. Crucially, not linked to a number. So it's not age 60 or 65. This is your state retirement age. So actually, Claire, when we send out copies of the slides, can we include a state retirement link? I'll send it across, but you can just check your state retirement age, but also very helpful to just check where you are in terms of accumulating your state pension. Make sure it's all on track and make sure the records are correct. In terms of the way this accumulates pension, you get 1/54th of your pensionable earnings for each individual year you pay in. So if I simplify it, excuse me, sorry. If you earn 54,000, 1 year of doing that will give you £1,000 a year as a pension. If you earn 27,000, 1 year of doing that will give you £500 a year. And then if you earn a different amount the year after, has no link to final salary. So the 500 or the £1,000 would simply be added to next year's pension figure. So if you just continue to earn 54,000 a year, you'd add £1,000 a year for every year you paid into the scheme. Now, here's something that's extraordinary about this scheme and the other two schemes for GPs, but this one for everyone. If you pay in to the NHS pension now, all of your earlier benefits, as long as there's a gap shorter than 5 years since you last paid in, are increased by Consumer Price Index plus 1.5%. The pension, whilst you're paying into it, the earlier benefits rise by more than the cost of living. So it uses the September figure, so 3.8% for last September. It's applied every April, but it means your pension grows by more than inflation. It's extraordinary. When any of the three pensions are in payment, they only grow in line with inflation. So Consumer Price Index. And again, it uses September's figure. But whilst you're paying in, it's growing by more. Just to run through the actual rest of the slide, the career averaged revalued earnings. And to translate what I've just said, exactly as described, it's calculated year by year individually, and they're added together. And again, as I mentioned, no automatic lump sum. You can give up £1 of pension for £12 of lump sum, and again, you decide that at retirement. And given that state retirement age, I don't think Rachel Reeves announced this, is now 105. Late retirement could well be very late. At the moment, state retirement is a maximum of 68. So if that's you, late retirement will be after 68 and still working and still paying into the scheme. Still generous, but as I mentioned earlier, please be aware that means you're retiring later and therefore you're shortening retirement. So try and factor that into any sort of thoughts and planning. Can we have a next slide, please, Claire? Thank you. This is perhaps the most important slide for the day, actually. It's the least fun for sure. So I'm hoping many of you have now heard about the age discrimination case, or the McCloud Judgement. And it's brought about lots of significant changes, all of which should be good for just about everyone listening in. In short, I mentioned that the 2015 scheme is the only scheme you're now paying into. Well, if you were previously paying into either of the other schemes, be it 95 or indeed the 2008 scheme, and you were moved automatically because you were too young, and they moved you into that 2015 scheme based on your age, and they moved you before the 1st of April 2022, you were moved illegally. As a result, when you retire, you're going to be given two options. Option one, I would like all of my service to be retained within my old scheme to the end of March 2022. So if that's the 95 scheme, that will give you an enhanced pension and indeed enhanced lump sum. If it's the 2008 scheme, it will just give you a greater set of pension benefits. Or whenever I would have joined the 2015 scheme, the earliest could have been the 1st of April 2015. I would like that date to be when I really joined it, and everything since then is now in the 2015 scheme. And if I give you some examples, the best or worst example, sadly, was ill health retirement from last year, where it actually worked to have the membership in the newer scheme rather than the old one because of the enhancement. So it's not cut and dry that the automatic position will be I'll simply go back to my old scheme. It'll be dependent upon what works for you. But please be aware that's how it's going to work. So in short, the age discrimination case will give you these wonderful choices. And best of all, if you haven't already retired, as you move forwards, it's going to give you the numbers. You'll be able to see, well, actually, I'd like to opt for option one, which is all back in the old scheme up until 2022, because it gives me access to the pension and lump sum earlier and so on. Or actually, I'd like it in the newer scheme because it gives me enhanced benefits or whatever it may be. But those numbers will be bespoke to you. They'll be your individual figures. And then in terms of the bullet points on this slide, a couple of considerations that you need to be aware of. Is everyone familiar with the annual allowance? And crucially, has everyone now started to receive or already received their remediable pension savings statements? If you haven't, Claire, I'll pop an email address, not mine, but for NHSBSA, so they can make a request. An RPSS, famously now known as a brown envelope. In short, it gives you all of these revised annual allowance growth figures, which have caused grey hairs, and I'm not sure if it's coming across on the camera, which will purely be the filter, nothing else, for many of us, because we've had clients that have gone from very modest growth in their pension to enormous numbers, and it doesn't look logical. We can have someone that is working one session a week as an employee, but being a GP, and that one session has inflated their pension benefits, causing a tax charge. They could literally earn hundreds of pounds a week, and it's caused thousands or tens of thousands as a tax charge. That's an extreme example, but it has happened. These statements, if you have received your RPSS, please ensure you forward them to your accountant. And I mentioned the benefit of medical specialist accountants earlier on. If you forward it to your accountant and your accountant says, what would you like me to do with it? Good time for a beauty parade on specialist accountants. If you need names and numbers, we can share names and numbers. But if you have a good one, they'll say, great, we've been waiting for this. We think you owe some more tax, or better still, we think you're due a refund. And we're probably now looking at about 3/4 of the RPSS figures we've seen have been due some modest refund, and about 1/4 have paid slightly more tax. It's worked out favourably for the majority. And again, just to break that down a tad further, some rather unique scenarios to this outcome for the McCloud Judgement. If when you look at your service, you and this RPSS, you've actually inflated your pension significantly in 2018, 19 or earlier, here's the really good part. As long as you've squared that tax bill before, you don't owe any more tax. And the reason for that is deemed to be out of scope, which is a wonderful phrase. It means our HMRC will not be asking for more tax. And then here's the ridiculous part of that, the reverse. If you're due a refund from 18, 19 or earlier, you're going to receive it, either because you use scheme pay, so the loan against your pension, and they'll simply amend that and the reduction to your pension will be lower. Or if you paid the tax charge itself, they'll give you a monetary return. It's extraordinary. And then 2019-20, if you're a frontline clinician and you now owe more tax, you should be able to offset that with the compensation scheme, but you may need to submit an application. And then last one, if I may, contingent decisions. So did anyone opt out of the NHS pension at any stage between 2015 and 2022? Did anyone stop added years? Did any of you simply change what you were doing with the pension because you were running into tax charges or similar? If you did, contingent decisions is going to give you the opportunity to say, well, I opted out for 3 years during that period. Can I see how much it would be to buy them back in my old version of the scheme? I opted out because actually it was causing me annual allowance charges, lifetime allowance charges, or I'm not going to retire at 67 or 68. I was moved into a new scheme and so on, so I stopped. And if that is you, contingent decisions are staggeringly good. A staggering opportunity to buy back service in your old version of the scheme to benefit potentially the pension and lump sum, depending on which version of the scheme you're in, but within your old scheme. And even better, you're able to apply hindsight. To buy back those 3 years is going to cost you £50,000. Okay, well, that's quite a sizable amount. But what do I get? Well, hang on, you get tax relief. Okay, so that's better. How much extra pension do I get? Well, you get this. Extra lump sum, well, you get this. Annual allowance charges, okay, they're these. You're actually able to apply all of it to see how it works through. You can see if it leaves you better off. We're going to see a lot about contingent decisions over the next, I would imagine, 18 months to 2 years. And although I mentioned added years, one thing that's rather unique there is that we have a lot of clients that stopped added years, that can no longer return to them and so on, that actually would have preferred to have kept them. Added years are an afterthought. So it is going to be impacted by contingent decisions, but genuinely, I have this email in my inbox. We're not sure how we're going to treat added years for contingent decisions. That's direct from NHSBSA. So if they're listening to that recording, I've got that email. So whenever that is announced formally as to how added years will be reinstated or not, and how the costs will be funded, perhaps Claire will organise another session or just a separate session. But certainly it's an opportunity for many to make good on their pension contributions all the way up until the end of March 2022 within their old version of the pension scheme. Wonderful news. It just needs to be clarified. Next slide, please, Claire. No question, this is my favourite slide. Claire has heard me speak on this one a few times now. It's a wonderful opportunity to access your pension. So all 3 schemes, I've given you the normal retirement ages for each, 60, 65, and indeed state retirement age. If you want to take your pension benefits earlier, you can. But you lose just under 5% of the pension benefits for every whole year you retire early. Calculated month by month, but it's just under 5%. So if you have the 1995 scheme, for example, and you went at 55, you lose about 20% of the pension and about 12% of the lump sum. And you lose that forever, but of course it's paid 5 years early and so on. So I took 2 phone calls pre-budget on the same day, ironically, from different people aged 50, desperate to take their NHS pensions because Rachel Reeves was going to take their lump sums. Age 50, you would lose about 40% of the pension forever. When I explained that, they were less interested in taking it. But the fear that was being circulated was extraordinary. So neither of them took their pension. But it was panic pre-budget. Lots of people worrying about it. So what I would suggest is that for GPs listening in, please make sure you've got a partnership agreement. And I know we're crossing over different departments here, but effectively, if you have a partnership agreement, make sure it includes the ability to retire, be that 24-hour retirement, so now known as retire and return, or partial retirement, or indeed just full retirement. And a couple of considerations here. One thing that is really important, both of the retirement options on screen, 24-hour and partial, give limited change clinically, but can potentially be still classed as retirement. So it may well be that your practice agreement limits the options you've got to one GP every 6 months or 12 months. Well, hang on, 24-hour retirement could literally be 1 day off. Today could be your last working day. Wednesday could be your day of absence. Thursday could be your day of return. That's one clinical day, and you may not even work that clinical day. So the impact to patients and clinical output could be negligible. Partial retirement is slightly different. You have to have at least a 10% reduction to commitment to the practice for a year, but that's all. So if you're single-handed, and if we have any single-handed GPs listening in, partial retirement has been staggeringly good news. It now applies to all three options within the NHS pension. And here's the best part, excuse me. If you are a single-handed GP and you took 24-hour retirement, potentially the list would go out to tender. You'd either have to join a partnership, you'd have a partnership agreement with the practice next door, the same practice you'd never joined as a partnership because either you didn't like each other or just didn't want to work together, and so on. Or the list could go out to tender. Partial retirement has changed that completely for single-handers. So simplifying that, if you're working 10 sessions a week and you take one session off, so you're not in on a Friday morning or a Friday afternoon, for example, for a year, and you replace yourself with a nurse, an administrator, or whomever for that one session, no risk to the list being lost, and you've accessed your NHS pension. It's been a staggering change. The key components for either of these, make sure you get written confirmation from the practice. So this applies to GPs and employees. So for GPs, it'll be normally within the partnership agreement or not, but make sure you get written confirmation from the partnership and indeed the ICB. I'm stopping today, tomorrow off, I'm back on Thursday, or I'm having a 10% reduction, which is a Friday morning, and I'll increase that in a year's time, or maybe I won't. And the partial retirements we've seen so far, interestingly enough, I can't think of any that have gone back up. Quite a few have gone below the 10%, so they've taken even more off. Make sure if you're an employee, so practice manager or similar, make sure the practice agree that you can take your pension. Make sure they agree to what you want to do work-wise when you come back. So if it's partial retirement, you're just dropping hours. You have to drop 10% of your pensionable pay for a year as an employee. As a GP, it's 10% commitment to the practice, slightly different. If you're taking 24-hour retirement, it's just a day off, but make sure you get written confirmation of the hours you're going to return on. Is it 37.5? Is it 30 or whatever? Make sure it's written down, confirming what you would like and what the practice would like. And then sadly, at the very bottom, I mentioned ill health retirement earlier on. It's ever increasing, it seems. Last year, I dealt with 11 ill health retirements. So far this year, I've dealt with 13. And there's still a month to go, technically, so that could rise further. Ill health retirement is something we're perhaps more aware of than ever. And it can be illnesses we'd almost expect, heart attack, cancers, and so on. But actually, last year we had long COVID and other issues, just a multitude of health issues. So I'm not trying to encourage ill health retirement, but being in the NHS pension tries to protect you. It does give you potential for ill health retirement. It does give you potential for death in service benefits. For those of you that have children under the age of 23, there'll be a payment to them on an ongoing basis. For those of you with a civil partner or spouse or financially interdependent other, there could be a payment to them for the rest of their lives if a disaster occurred. So the scheme itself is very good, but understanding it is absolutely imperative. And making sure, and this is a dangerous comment, making sure PCSE have updated your records is absolutely essential. And if they haven't, what I'll do is I'll email Claire just some ideal scenarios, so you can just simply cut, paste and send to either NHSBSA or PCSE if needs be. Next slide, please, Claire. And not quite my favorite, although the vineyard with sun would be lovely at the moment. Just when. One crucial point here is that although I've given you ages, I've given you 60, 65 and state retirement age, don't be driven by those. Change the thought process to how much do I or how much do we need in retirement to do the things we want to do. For some, it'll be 1,000. For some, it'll be 10,000 a month. Whatever that figure, make it about you. We want to walk more. We want to read more. Well, good news, both of those are quite cheap. I want to attend the theatre. We want to travel. Okay, was slightly more expensive. But try and write down where you are and where you'd like to be. What does the next 5 years look like? What does the next 10 years look like? Because what it could well be is that, well, we think we only need 2,000 a month or 3,000 a month or whatever the figure. You may already have that. You may have that from your NHS pension, your state pension, your savings, a rental property, whatever it may be. You may have that. So when traipsing into work, fearful it's another Monday morning, I'm going to have a million emails in the inbox because any patient can email. We're allowed to now. I'm terrified that I'm going to overrun on Monday and into Tuesday and so on. Well, hang on. If you're doing that by choice because you've got enough already banked to do the things you want to do, that's different to I've got to do this for another 20 years, another 10 years, another 5 years. So please make it about you and make the planning around slowing down and stopping around what you'd like to be doing, because retirement's meant to be fun. You're meant to have more time to do things that you couldn't do whilst you're in a practice. So whilst you're looking after us as patients, be that the team at the front door, be that the medics or any other member of the GP practice, you're not able to do everything that you would like to do. So write them down. And one thing I would suggest is that be careful if you have any debts or liabilities, credit cards, mortgages and so on. If you run into retirement with those, you're paying interest. We don't know what interest rates are going to do. We don't know if they're going to rise, they fall or whatever. If you're at the mercy of others and your income drops and interest rates could potentially increase or whatever, that could leave you worse off. So working an extra year, an extra 2 years to clear debts and liabilities, that may leave you better off forever. So just take stock of where you are, write down the things that you'd like to do, the exciting things, write them down, tick them off, try and put a value on them. Will traveling to France be £1,000, £5,000, whatever? Write it down, because if you do that, you can actually try and work towards it and making it happen. Thanks, Claire.
Thank you, Paul. Gosh, so much food for thought. I don't even know what to digest first. A smorgasbord.
Sorry.
Just like the budget was. That's all right. Just like the budget was going to be. We have a little bit of time for any questions, if anyone has any. Thinking back to the ones that were submitted in advance, Paul, while other people are putting stuff in, there was something about salary sacrifice. Did you cover that?
No, I didn't actually. You're right. So one of the questions that came in before the session was, how will the salary sacrifice changes impact me and my NHS pension? It's a really good answer. It won't. The NHS pension is not salary sacrifice. So there are no changes. The limit to £2,000 and thereafter it's going to face some NI changes and so on doesn't apply. So the the salary sacrifice changes do not impact your NHS pension.
Good to know. Nice, easy one. Thank you,
Yes.
Paul. I might just pick up on what you mentioned about partnership agreements and how important it is to get one or to try and get one before you retire. Because retirement, in my experience of mediating partnership disputes, can be the thing that triggers a dispute.
Yep.
And if you don't have a partnership agreement, then you might not even have a mechanism, never mind 24-hour partial retirement, just to retire. You may be locked into your partnership for a while because you were last in, and there's a big queue of people at the door to retire. But there's all sorts of other reasons why it can get difficult. So I'm diddling myself out of work here, but if you have not got a partnership agreement, it will pay for itself a million times over if you can manage to get one. There'll be less to argue about. There'll be a framework for how you can resolve things. If you're one of those partners that says, I don't need a partnership agreement because I get on beautifully with my partners, what you're actively then sort of signing up to by choosing not to have a partnership agreement is you're instead saying we're happy for the 1890 Partnership Act to govern our partnership and be our partnership agreement. That's how much we like each other. But the 1890 Partnership Act is a load of rubbish, particularly for well, any modern day business, never mind a general practice. Profits are shared equally. Nobody can retire. Nobody can die. It's a total. It's useless. So you must not stop yourselves from getting a partnership agreement because you think you get on well enough, because you're kind of kidding yourself a little bit. What you are then saying is that you're wanting to use the 1890 Partnership Act. And then you just have to remember to take it the next step. If you do all agree to have a partnership agreement, and this might sound silly, but to make sure you then actually do it and make it valid.
Yep.
Having a partnership agreement that you've forgotten to sign is something that somebody can just challenge later. Having a partnership agreement that you've all signed, but nobody, not even the practice manager or your solicitor or anyone, has a copy of it anywhere, that's another thing that somebody will then challenge it and say, well, it doesn't exist. If you've got a partner on a mutual assessment, somebody that's joined, and they've joined without signing on to anything, even if it's a piece of paper called a deed of adherence, which means they're signing on to your partnership agreement, then you've no longer got a partnership agreement. You're a partnership at will. So you just have to be very, very cautious and make sure that not only have you got one, but that it's completely valid and nobody can challenge its existence, because then you're in a pickle again. And people will sometimes try and do that in a dispute, because it can work favorably for somebody in a dispute to sometimes say, actually, we don't have a valid partnership agreement. Sorry, you can't rely on all of those clauses in there that you're trying to use right now. So that would be my sort of one major, but hopefully simple tip that pays for itself to help you kind of narrow down your disagreements, financial and otherwise, that you might have as a partnership. Anything you wanted to say on that, Paul?
Just to extend your point, one thing that occasionally we come across, and I guess you would come across slightly more, is that we've got a partnership agreement. It's okay. The solicitors round the corner have drawn it up. Now, that's okay if you're round the corner from the likes of BMA law, DR solicitors, VWV, and all the medical specialists. If it's a non-specialist solicitor drawing up a GP partnership agreement, they can quite often miss things. There are some that will be very good, but they can quite often miss GP specific components. So please just take stock of the organization you're using for your partnership agreement, because making sure that it's correct and valid for what you want to achieve is much better. There's a question from Deborah, actually. If you haven't got any children or spouse or anyone you'd like to receive your death benefits, crumbs, what happens to this? Right, Deborah, that's a tough question, actually. Sorry. I'm killing you off now, Deborah. So a very brutal response. If you had died yesterday, and there are no children or no spouse at the moment, there would still be a death in service lump sum payable. Now, if you haven't nominated any form of beneficiary, that would potentially be paid to your estate. So depending upon the value of your overall estate, that would be inherited by whomever. So we mentioned partnership agreements just then. Similarly with a will. or nomination of a beneficiary. I don't think Claire or I can volunteer to be your beneficiary. I think the pair of us would be struck off on that front. But you can nominate whomever, or you can place that within your will. So it could well be your siblings, it could well be your parents. If you haven't got a will, then dying intestate would mean that it would likely go upwards to parents. So please be aware of that. But there is still some payment in terms of a lump sum. There's not an ongoing income forevermore, I'm afraid. So that income would effectively be lost. The best way around that, avoid death. Very sound planning on that front.
Easy peasy. Thank you, Paul. And we've got something in the Q&A as well now. I don't know if you can view that one. I'll read it to you, shall I? Dear Paul, I've had my letter yesterday. I've had a letter from NHSBSA saying that I can't get my RPSS as one of my year's contribution certificates has not been sent to them. My accountant and I have sent it to them about 5 times. Totally believe that that would be the case. How do I sort it out?
I mean, firstly, just 5 times. What I shall do, so I mentioned a few times that I'll email Claire just some helpful email addresses and so on. It sounds as though something has gone wrong for 21-22. You're emailing a certificate that looks perfect to you and your accountant, but whenever it's being reconciled, my best guess here is either that the figures differ to what PCSE I have on file. So all that's happening is you're sending in the correct information as you guys think. It lands on their box or their inbox. They marry that up, and of course it's out of sync, so they simply decline it, not processed. And PCSE work on a chronological front, so everything could have been perfect since 22 onwards, but it won't show until 21-22 is resolved. I'll send that email address across to Claire, so you've got that. From an accountancy point of view, if they are medical specialists, and the fact they're doing the certificate is always a good sign. It may well be that the question to pose to PCSE is simply, my certificate is attached. It shows pensionable profits of X or Y. What do you have recorded? And then we'll try and make good the difference in figures. And it may well be they've made an error at their end, but sadly, the default position is they're correct until you prove otherwise. So that's very likely to be the scenario at the moment. Sorry.